So Nick, should I start by sharing my screen, or
Oh,
you want to wait until?
I
We
think
have a
Dr. Hangoro will put some sort of presentation video. Then I'll give a brief introduction and housekeeping. Then Nick will introduce you. Then invite you to talk afterwards.
Okay.
Is it okay?
Yeah.
Hi everyone. Assalamualaikum and welcome. Thank you for joining us today. We are glad to have everyone here. So before we get started, I just want to run through a few quick housekeeping items to help things go smoothly. Um, First, you'll notice that everyone is currently muted. This is automatic to help reduce the background noise. If you are on a shared Wi-Fi, we recommend minimizing any streaming or heavy internet use on other device during this session. And if you have any question as we go along, do feel free to drop them into the chat box and we'll address them during the question and answer session at the end of the presentation. So with that out of the way, let's get started. I'm very happy that to begin this event with inviting Dr. Nick to briefly introduce our today's speakers. It is very especially meaningful for him that he'll be sharing the speaker's background today, as this speaker is the one that played an important role in his professional pathway. Please join me in welcoming Dr. Nick to do the introduction.
Hey, good morning, good afternoon, and good evening, everyone, depending on where you are. Welcome and thank you for joining our third SEAUPS webinar. My name is Dr. Jirsit Sawinsapanan, or just Nick. I am the secretary of the SEAUPS, and it is a pleasure and an honor for me to introduce our speaker, Dr. Ming Zhao. Dr. Zhao graduated with highest honors from Fudan University Medical School in Shanghai, China, completed his pathology residency and training at the University of Michigan, and went on to pursue fellowship training in urological pathology at Johns Hopkins Hospital. Over the course of his career, he has held faculty and leadership positions at the Cleveland Clinic, New York University, the University of Texas Southwestern Medical Center, and Tufts University School of Medicine, where he served as chair and pathologist-in-chief from 2019 to 2024. Dr. Zhao is currently a professor of pathology at the Department of Pathology, Molecular and Cell-Based Medicine, Mount Sinai Hospital, and Icahn School of Medicine in New York City, where he serves as the vice chair for oncological pathology and director of the Urological Pathology Service and Fellowship Program. Dr. Zhao has over 20 years of experience and is nationally and internationally recognized as a leading authority in urological pathology. He has authored over 200 peer-reviewed articles and more than 100 review articles and book chapters, and has co-edited 5 major textbooks in urological and prostate pathology, including the AFIP Prostate Fascicle, 3 of which are now in their second editions. He has also guest edited journal issues in urological pathology and is a frequent invited speaker at national and international meetings. His professional service includes serving as the president of the Genitourinary Pathology Society, as well as the board of directors of the United States and Canadian Academy of Pathology. Dr. Zhao is also an outstanding educator and mentor who has trained and supervised countless residents and fellows. I am proud to be one of his former trainees, and I am very grateful for that experience and for his continued guidance and support. Dr. Zhao, the floor is yours.
Well, thank you, Nick. Let me share my screen. You can see my screen, right? It's a full mode, the presentation screen. Okay, great. Well, thank you so much, Nick, for the invitation and the introduction. And I first want to congratulate you and Dr. Jeff and other the leaders of the SEAUPS for the putting the huge effort into bringing together such a wonderful group of pathologists in the Southeast Asia. So you guys you're doing a great service and to the pathology and the population in general in that area. So today I'm going to talk about the diagnosis of unfavorable histology in prostate cancer, the implications for the patient management. So I will talk about the pathologic features that are not Gleason, but do impact the prognosis and management of the prostate cancer. We'll focus on the unfavorable histology of the prostate cancer, which I'll tell you in detail in the next 15 minutes. But let me first give you a very brief overview of the prostate cancer, which is a highly heterogeneous disease with respect to its biology, genetics, pathology, clinical presentation, treatment, and outcomes. Most of the prostate cancer, about more than 80% of them, are localized disease. They have a very indolent biological behavior with excellent 10-year disease-specific survival. The cancer-specific death is really, really low. These patients are treated with active surveillance, sometimes can also be treated with surgery and radiation. However, about a third of these patients will eventually progress to metastatic disease in the form of PSA recurrence, local, regional, and distant metastases. These patients are treated with the androgen deprivation, the treatment, or ADT plus chemo, ADT plus newer generations of the anti-androgen agents, such as enzalutamide. Despite of the initial response to these treatment, eventually these treatment will fail, and the patients will become so-called metastatic castration-resistant prostate cancer. And they will be treated with the newer the anti-androgen the therapies, targeted therapies, and immunotherapy. But unfortunately, the disease is incurable. Eventually, the patients will be succumbed to their diseases. So there are several key issues in the patient management. The first one is for the low and favorable intermediate risk patients, how can we identify those patients who are eligible for active surveillance so that they can avoid the surgery or radiation or avoid over-treatment? A second issue is for the patients with unfavorable intermediate, high risk, or high risk, very high risk disease. How do we identify those patients? After the initial treatment, they may recur. Therefore, those patients can benefit from additional adjuvant therapy to avoid undertreatment. So the many factors have been used to assess risk for those patients and guide their treatment plan. And Gleason the grade is one of the most commonly used factors. And we all know the Gleason grading system was developed by Dr. Gleason almost 60 years ago, and has undergone numerous modifications and revisions to adapt to the changing clinical practice of the cancer diagnosis and treatment. However, it remains as the single most important prognostic factor, and it's used in all the risk stratification tools and nomograms for the treatment decision-making. But Gleason grading system is not perfect. It still misclassifies risk, especially for the low and the intermediate risk patients. And I think that's the reason why many studies have looked for other non-Gleason pathological features to try to improve the risk stratifications for the prostate cancer patients. And these studies and research has culminated in a recent proposal from Wen and McKinney, to diagnose and report so-called unfavorable histology for the risk stratifications to improve the risk stratifications. And these unfavorable histology includes the following 5 features. The all Gleason pattern 5s, the large cribriform and the intraductal carcinoma, and anastomosis cords, complex intraluminal papillary structures, and grade 3 stromogenic prostate cancer. And most of the 3 features, the make up most of the unfavorable histology, seen in about 90% of the cases with unfavorable histology. The last 2 is quite rare, is seen in less than 5% of the unfavorable histology. And then the Wen and McKinney used this the method to stratify the patients in 2 cohorts, the radical prostatectomy cohorts. The first cohort had a long-term follow-up, and the second cohort had a pathology-confirmed metastases. And these the diagrams show that the results are really, really striking. And the patients with and the patients without the unfavorable histologies have a very, very different clinical outcomes. And the patients without the unfavorable histology have a very low the PSA recurrence, and none of them, I want to emphasize, none of these patients actually had the metastases or prostate cancer, the specific death. And this is true for the patients with high pathologic stage 3A and 3B, and also it is true for the patients with the grade group 3 prostate cancer. So therefore, the unfavorable histology at the radical prostatectomy is associated with the risk of metastases, and also it can predict adverse outcomes better than Gleason grading system and a staging system. So in the next the 30 minutes, I would like to just go over these unfavorable histology in a little bit more detail. First, let's look at the Gleason pattern 5. We know Gleason pattern 5 has several subpatterns, including solid sheets, cords, single cells, and comedal necrosis with the comedal necrosis. And so we all agree we should grade large solid nests with uniformly distributed nuclei as the Gleason pattern 5. And even for large nests with these non-uniformly distributed nuclei in a vague luminal formation, it should be graded as Gleason pattern 5. And how about these small and medium-sized nests? I think everyone agrees that the small and medium-sized nests should not be called the Gleason pattern 5. It should be graded as pattern 4. However, the size criteria to distinguish small versus large nests is not all that clear. That's the reason why we did a study about 10 years ago. We asked a group of the urological pathologists what size criteria or cutoff they use to distinguish between small and large nests. It turns out that they used 20 nuclei per nest as the cutoff for the large nests. So if a nest has fewer than 20 nuclei, then it should be regarded as a small nests and therefore should be graded as a pattern the 4. But really, we're not asking you to count all the nuclei in these other nests. Easy way is to just look at or count the nuclei along the narrowest diameter of these nests. If you see 5 or fewer nuclei along this narrowest dimension, then it's a small nest. It should be graded as a pattern 4. Single cells, the course of cells, whether they should be graded at pattern 5, is probably one of the most challenging the issue in the prostate pathology. So in that the same study I just mentioned, we also asked urological pathologists for their diagnostic criteria. It turns out that they use this 6 to 10 single cells, course cells in a cluster, or more than 10 in a cluster that the intermix with adjacent well-formed glands as the cutoff to grade the single cells, course cells as the Gleason pattern 5. Here's an example that I think everyone can agree. This is the single cells. Should be the graded as pattern 5 because you see numerous the single cells. And McKinney actually went further to the claim that if you want to diagnose Gleason pattern 5 single cells as unfavorable histology, you really should see single cells occupying a confluent region that is reminiscent of lobular breast cancer to qualify it as unfavorable histology. Of course, if you only see a few single cells or course of cells, like you see here, it's not Gleason pattern 5, right? I'm not sure if it can be graded as a pattern 4 in these the two images because they could just represent outpouching from the adjacent the well-formed glands. Now, if you see intraluminal coagulated necrosis, you can grade it as pattern 5, whether you see or you don't see the karyoretic debris. However, if you see only karyoretic debris without the coagulated necrosis, there's really no the consensus among the pathologists of whether we should grade it as pattern 4 or 5. So because there's no consensus, I would not grade it as a pattern 5. In this case, because it's a cribriform lesion, I will call it a pattern 4. And if you just see these amorphous the material without seeing ghost cells, it is definitely not the coagulated necrosis. It should not be called grade 5 or pattern 5. Now, let's talk about the large cribriform glands and the intraductal carcinoma. All right. So the cribriform glands, the definition is quite clear. You should see confluent sheets of the multiple the glandular lumens that can be easily visible at the 10x magnifications. And in these cribriform glands, you should not see a lot of stroma or mucin. The diagnosis of cribriform glands is obviously very important, and it is one of the most important diagnoses in the prostate pathology. So this the expansile growth you see in cribriform glands is indicative of aggressive the behavior, and it is the worst the Gleason pattern 4 and independently predicts PSA recurrence and metastases. And also, if you diagnose cribriform cancer in a prostate biopsy, it's predictive of advanced pathologic stage and upgrading at the radical prostatectomies. has had important management the implications as well. According to the U.S. National Comprehensive Cancer Center Network, if the prostate biopsy has cribriform glands in it, then the patient is not suitable for active surveillance, and the patients are recommended to undergo germline testing for DNA repair genes. And so of all the Gleason pattern 4 subpatterns, the cribriform cancer glands have the best inter-observer reproducibilities, but it's still, the overall diagnostic agreement is still only fair with the kappa value being 0.4. That is because there's really a lack of the precise definition for the cribriform glands. So that's the reason we and several other groups have conducted a few studies, and we put forward a set of the diagnostic criteria for cribriform cancer in an effort to improve the diagnostic accuracy. So we suggested that to diagnose cribriform cancer, you really need to see dense cellular proliferation that forms this transluminal bridge, and you should see less than 50% of the clear space along the glandular periphery. And you really shouldn't see a lot of stroma vessels and mucins within the cribriform glands. I think everyone can agree that this is a good example of cribriform glands. You can see this dense proliferations of the cells that forms these cellular columns that spanning the entire lumen of the glands, and you see the many the sharp punched out lumens. This is a good example of cribriform glands. And in these glands, you see these large expansile the glands. You see some large clear spaces at the periphery of the gland, but they occupy less than 50% of the glandular periphery. You can still diagnose these as cribriform glands. However, if you see these cellular the columns only partially bridging, or you see a lot of stroma vessels or mucin in the glands, or you see this so-called glomeruloid pattern with a single attachment to the gland border, or you see these clear space along the periphery of the gland that occupies more than 50% of the glandular circumference, then you should not call those the cribriform glands. For example, in these glands, these are large glands with very the florid the glandular perforations. However, these cellular columns only span part but not entire lumen of the glands. So you see partial bridging. This is not cribriform glands. And in this large gland, you see a lot of mucins, then you should not call this the cribriform glands. And in these glands, you see these cellular mass and have one or single attachment to the gland, the wall. So now this is glomeruloid glands. They are not cribriform glands. And if you see these a lot of stroma within the gland, right, then these are not cribriform glands. And in this picture, you see a large cribriform gland in the middle of this gland. However, you see these clear spaces. Well, first of all, you see the multiple attachment to the glandular wall, and also you see these clear spaces that occupy more than 50% of the glandular periphery. There's actually no consensus among urological pathologists whether we should call it the cribriform gland or not. So because of that, I would not diagnose this as a cribriform gland. So some cribriform glands are small, some are large, and so we're questioning whether you should call the cribriform gland small or large. And there's important reason for doing that, because the studies have shown that only large cribriform glands are an independent predictors of the clinical outcomes. So that is the clear. What's not clear is what criteria we should use, because there are quite a few the criteria for large cribriform gland. For example, the large cribriform gland should be the more than twice the size of the adjacent benign glands, or should have more than 12 lumens, or should be the bigger than 0.25 the millimeter, or half of the 40x field. Emily Chen and her group actually looked at the different sizes and their the correlation with the clinical outcomes. And you can see that when these cribriform glands the increase in size, and the clinical outcomes becomes worse. However, the no cribriform glands, and when the cribriform glands is less than 0.5 millimeter, they have the same clinical outcomes. In contrast, for the cribriform glands that are bigger than 0.25 or bigger than 0.45, they have the same the clinical outcomes, meaning that if the cribriform gland is absent or less than 0.25, it has a very different clinical outcomes than those cribriform glands that are bigger than 0.25 millimeter. So the 0.25 has been chosen to be the cutoff for the large cribriform glands. So I use this the cutoff. So, but how do we measure the size of these cribriform glands, right? In the Emily Chen's study, they suggest that we should not measure the long axis of these cribriform glands. Instead, we should measure the cross-sectional diameters of these cribriform glands. For example, in this case, if you measure the longitudinal diameter, it will be more than 0.25 or half of the 40x field. However, if you measure the cross-sectional diameter, it's less than 0.25. Therefore, it's not a large cribriform gland. Now, let's talk about the intraductal carcinoma of the prostate. It's recognized by WHO as a distinct prostate cancer subtype. In the 5th editions of WHO classification, it's defined as a neoplastic epithelial proliferation that involves pre-existing and generally expanded duct acini structures, and characterized by the architectural and cytological atypia, the beyond what's the accepted for a high-grade PIN. So the mechanisms of the pathogenic mechanisms for IDCP that has been hotly debated. I think Nick and I wrote a review articles not long ago. If you're interested, you can read that article. But there are two possible mechanisms. In most of the cases, the IDCP results from the retrograde spread of a high-grade invasive prostate cancer that invades back into the pre-existing duct and acini. Then they will grow and proliferate within the duct acini structures. This is supported by the findings that the IDCP and invasive cancer are often, in most of the cases, are found together. And they also share the molecular genetics and the common the genetic the ancestry. Really, the intraductal carcinoma represents a transformation and intraductal proliferations of these precancerous lesions. So these precancerous lesions will proliferate and remain in the duct acinar structures until very late when they can break through these glands and the duct to become invasive cancer. That's because in rare cases, you may see intraductal carcinoma without concurrent invasive cancer, or the intraductal carcinoma is found adjacent to only the microinvasive prostate cancer. Regardless of what the mechanisms for the intraductal carcinoma, IDCP is a bad actor in prostate cancer pathology. So Chow et al. Actually coined a term, prostate cancer nimbosis. And we know the nimbosis is Latin for stormy clouds. The prostate cancer nimbosis really means the constellation, a collection of unfavorable histology that includes both IDCP and cribriform cancer in the molecular characteristics that will forecast aggressive biological behavior and poor clinical outcomes. And it is true that IDCP has a very important clinical significance because the vast majority of the cases are associated with high-grade and stage prostate cancer. It is also associated with the adverse pathology outcomes and clinical outcomes in both radical and biopsy specimens. And has important clinical management as well, because the patients with the IDCP diagnosis in the biopsies are not eligible for active surveillance, similar to same as for the cribriform cancer, and also same as the cribriform cancer. The patients are recommended to undergo germline testings for DNA repair genes. So IDCPs has a very important morphological landmarks. You should see expansile growth of the cancer cells that form this cribriform or solid architecture, which is the morphology indicative of aggressive growth. And these proliferative cells are confined to the native the prostate glands, with the basal cell layers at least partially preserved. You can appreciate that or confirm that with the IHC for basal cells, right? The intraductal carcinoma usually involves numerous large glands in both the radical and the biopsy specimens. But in the biopsy specimens, sometimes you may see just one or few glands involved by the IDCPs. Compared with adjacent benign glands, IDCP glands are usually much larger, and they often have this expansile the contour. And you may see a number of the patterns, including loose cribriform and dense cribriform, which is defined as these punch-out holes, clear spaces, less than 50% of the glandular lumina. You may also see solid and comedial necrosis. And sometimes you can see this corpus amylasia in the IDCP glands, or the IDCP glands partially involves benign glands. These are the features that support the notion that IDCP is really is involving these pre-existing the benign glands and ducts. The IDCP also has a profound nuclear atypia. You often see the marked variations in nuclear size and a very prominent nucleoli. Very rarely, you may see these very prominent the pleomorphic and the humongous the nuclei in the IDCP glands. Sometimes you may see these two-cell populations with the cells in the middle of the glands that look like they have these small, dense nuclei. The cells will look like a small cell neuroendocrine carcinoma, but studies have shown they actually don't have the high-grade nuclear endocrine differentiations. This table lists several diagnostic criteria that have been put forward by different authors. They all look very similar to each other, and they all are based the diagnosis on three things. First, you need to see these lumen spanning tumor cells that form different patterns, including cribriform, solid, and comedial necrosis. And you should see the significant nuclear atypia, and the basal cells should be preserved. But the diagnostic criteria proposed by Gore and Epstein is one that is recommended by the WHO and the most recently by GUPS and ISUP. To diagnose the intraductal carcinoma, you first need to see the large cribriform glands that are expanded by malignant the cells, and you should also see the basal cells in those glands. And from there are two ways you can make a diagnosis of IDCP. First, you can, if you see solid or dense cribriform or comedial necrosis, you have your diagnosis. If you don't see any of that, instead, you see loose cribriform and a micropapillary pattern. If you see extreme nuclear atypia, you can also make a diagnosis of IDCP. The diagnosis is really, you don't need to do the immunostains, but in some borderline cases, you can do the immunostains to confirm, right? You can do the PINK4, which should show preservation of the basal cells and positive AMACR expression. ERG gene fusion product is present in about 75% of the cases, and P10 loss is seen in about 90% of the cases, right? Very important. If you see IDCP and invasive cancer together, in most of the cases, you should see the concordant expressions between the IDCP and the invasive cancer. But all IDCPs are not created equal, because I mentioned almost always IDCP is associated with high-grade and high-volume invasive cancer, right? However, IDCP can really be an isolated diagnosis without seeing invasive cancer, or even rarer. You may see IDCP is associated with a Gleason score 6 prostate cancer. And I see IDCP without invasive cancer diagnosed in prostate biopsy is very rare, right? Has been reported so far in only 2 cohorts of 83 patients, right? Of those patients who underwent the prostate radical prostatectomy specimens, majority of those patients, about 57%, actually had a high the pathologic stage, 3A and 3B. And the Gleason score in those patients is also very high, almost 8, with a range from 7 to 10. And 37% of those patients had a primary or secondary the Gleason pattern 5, and 11% had the Gleason tertiary pattern 5. And during follow-up, 6% of those patients had bone metastases, and another 6% had a PSA recurrence. So needless to say, the IDCP, even without invasive cancer, when diagnosed in prostate biopsies, indicates an aggressive disease. So that's why the NCCN, the recommendation of the treatment guidance, recommend these patients be managed just like the patients with invasive prostate cancer. And the biopsy with Gleason score 6 cancer and intraductal carcinoma together is even the rarer. It's reported in only 1 study of 62 patients. These patients really, they have a very aggressive the clinical presentations. At the presentation, the PSA is quite high, 14, which they can go up to 400. And 4% or 6% of patients presented with bone metastases. These patients were treated with different other modalities, including radical prostatectomy, radiation, active surveillance, and other treatment methods. However, after treatments, right, 19% of the patient presented or developed bone metastases during follow-up. The conclusion from this study is even when IDCP is diagnosed, associated with the grade group 1 cancer, it is still an indication of a poor prognosis. However, in 3 of these patients, when they had the radical prostatectomies, these 3 patients only had a Gleason score 6 cancer, and 2 of them had a no biochemical recurrence during the follow-up. Suggesting that the minority of these patients with a diagnosis of Gleason score 6 cancer and intraductal carcinoma in the biopsy could still be an indolent disease. So in terms of how to report IDCP in the presence of the invasive cancer, so about 5 years ago, GUPS and ISUP they put forward 2 recommendations. Right, these recommendations they are similar to each other for a large part, but they have a very significant difference in one aspect. That is, when IDCP is found in the presence of invasive cancer, the GUPS recommend not to grade and include IDCP in the final Gleason score. And ISUP, they recommend the opposite. You should grade and incorporate IDCP in the final Gleason score. Unfortunately, 2022 WHO Blue Book didn't endorse either position, and this caused a lot of confusions among pathologists and clinicians, and making grade and outcome data comparison very difficult in published studies. But I'm very happy to tell you that recently GUPS and the ISUP had finally come together and put forward a unified recommendations for how to report the intraductal carcinoma. So this is a summary of that recommendation. So first of all, IDCP should be graded and incorporated in the Gleason score with invasive cancer. That includes the cases with grade group 1 cancer and intraductal carcinoma. And in those cases, IDCP should be graded based on its morphology. If it's cribriform, it should be graded as pattern 4. If it's solid with necrosis, it should be graded as pattern 5. And in rare cases, IDCP can be diagnosed based on the marked nuclear atypia. But when in those cases, the IDCP should not be graded together with the invasive cancer, because we have no data so far to the support of that. And also, IDCP should not be graded if it is spatially separated from invasive cancer. For example, if you have 2 biopsy parts, one part has invasive cancer, the other part does not have invasive cancer, instead it has the intraductal carcinoma, then you should not combine these 2 parts together and grade intraductal carcinoma. Instead, you should call one part invasive cancer, grade it, and the other part has the intraductal carcinoma. And obviously, isolated IDCP without a concurrent invasive cancer should not be graded. In addition, the presence and the grading of IDCP should be documented in a comment saying that the IDCP is present and IDCP is included in the Gleason grading. Right. So an important issue is whether we need to distinguish between intraductal carcinoma and cribriform cancer. But I will argue we shouldn't, because both show the cribriform morphology. and not always possible to distinguish based on the morphology alone without doing IHC for the basal cells. And the studies have also shown both associated with the increased genomic instabilities that are clustered to genetic regions involved in the aggressive prostate cancer, and both shows a negative the effect on the prognosis. I mentioned that this new concept of unfavorable histology includes both cribriform and IDCP. Therefore, there's no need to distinguish between the two. As a matter of fact, there are several the proof of the principle and the studies that explored the ways to incorporate cribriform the morphology, including cribriform cancer and intraductal carcinoma, in the Gleason grading system to calculate the so-called cribriform Gleason grading system. So it works this way. For the grade group 1 cancer, if you see intraductal carcinoma, then the cribriform Gleason grading, the grade is the 2. For the grade group 2 to 5 cancer, if cribriform morphology is present, then the cribriform Gleason grading remains the same. If it's absent, then its cribriform Gleason grade drops by 1. So the cribriform Gleason grade for a grade group 2 cancer without invasive without cribriform morphology will be cribriform Gleason grade 1, so on and so forth. And this study have shown that this cribriform Gleason grading system provides a better discriminative value for the clinical outcome and represents a simple modification of the Gleason grading system, particularly the affects the treatment decision-making in men with the current grade group 2 prostate cancer. So IDCP really is represents a intraductal proliferation, right, which is has a morphological spectrum. At one end of this spectrum is high-grade ping. At the other end is the intraductal carcinoma. But invariably, you're going to see in the middle of the spectrum, the lesions, that they have the morphology that's the worse than the high-grade ping, but not enough to diagnose intraductal carcinoma. What should we call these lesions? The recommendation by ISUP and the GUPS is the atypical intraductal proliferation. So these are several examples of AIP. You can see these biopsies and all show these large the expansi of the glands. They have a more complex glandular proliferations, more complex than the high-grade ping. And in some glands, you see these florid the papillary proliferations. In other glands, you see these loose cribriform the architecture, certainly not enough to diagnose the intraductal carcinoma. In these two examples, you see these loose cribriform architecture, and in these two biopsies, you see these proliferations that partially involves a gland. Again, not enough to make a diagnosis of IDCP. So the ISUP and GUPS recommendations suggest that you should diagnose IDCP only when the intraductal proliferation of proliferative lesions is really strongly suspicious for, but not enough to make an IDCP diagnosis. For those intraductal proliferative lesions at the low end of the spectrum, only mildly, those are the lesions only mildly suspicious, the atypical than the high-grade ping, but certainly far from a intraductal carcinoma. Those lesions should not be diagnosed as AIP. Instead, they should be diagnosed as the high-grade pings. And in a suspicious lesions, right, you can do the ERG and P10, the IHC. So a positive ERG and the loss of PTEN certainly favor AIP over the high-grade PIN. And also, the AIP suspicious for IDCP is a better diagnostic term than AIP alone. So the recommendation is to diagnose these lesions as AIP suspicious for intraductal carcinoma. Yeah. So AIP they may represent a low-grade morphology of IDCP because studies have shown that the prostate cancer with IDCP and the prostate cancer with AIP have a similar clinical pathological features, and AIP and IDCP also share molecular features such as loss of PTEN and expression of ERG. So when diagnosed in the prostate biopsies, AIP is a potential marker of unsampled IDCP and also predicts the adverse pathology or unfavorable histology in radical prostatectomy specimens, including Gleason pattern 5, intraductal carcinoma, and cribriform prostate cancer. So that's why for AIP, the diagnosis in the prostate biopsies, NCCN, the guideline recommends these patients undergo repeat biopsy using AMI targeting and the systemic prostate biopsy to look for invasive prostate cancer. So for the AIP, we definitely need to report it for both radical and prostate biopsies, but different from the AIP, different from the IDCP, AIP is not graded and incorporated in Gleason scores. So the anastomosing course is another unfavorable histology. This is here are a few examples. So you can see these these cords that are connected together. They may be solid, therefore they will be graded as pattern 5, or they may have these cribriform morphology, which will be graded as a pattern 5. And intraductal papillary proliferation is another form of unfavorable the histology. Here are two examples. On the left, you can see these the papillary proliferations within this gland. These papillary structures are true papillary structures. They have well-defined fibrovascular cores, and they also have this lined with these columnar cells with elongated nuclei. This will be your examples of ductal carcinoma of the prostate. On the right, you also see this florid papillary proliferation with well-defined fibrovascular cores. Right? These are true papillary structures, but they are lined with the cells of the typical acinine morphology. So far, I've talked about the morphology of the prostate glands, right? But we all know that the tumor microenvironment also play a very important role in the treatment response and the disease progression. These include extracellular matrix, inflammation, vessels, and the fibroblasts in the prostate stroma. And this table lists some of the key stroma the components that are clinically important. For example, if the stroma is quiescent and have a low immune cell infiltrate, that usually indicates that the patient, the cancer has an indolent clinical behavior. The patient may be eligible for active surveillance. And this stroma is something a pathologist can see under microscope. For example, this benign stroma it is composed of abundant of the smooth muscle the cells with eosinophilic the cytoplasm. Most of the prostate cancer really doesn't have a stromal response. And the stroma will just look like a benign stroma. It's composed of abundant the smooth muscle cells. However, in rare cases, you can see the cancer stroma looks very different from your benign stroma. And it is loose. It has this the bluish tinge because of the new collagen formation. If this the reactive stroma is more than 50% of the cancer, then it's called stromogenic prostate cancer. In stromogenic prostate cancer, you also see the characteristic morphology of the cancer glands. They often have this squeeze morphology. These cancer glands appear elongated or angulate, as if you are pinching the cancer glands. So studies have shown that stromogenic the prostate cancer correlates with increased risk of the biochemical recurrence, progression, and the prostate cancer specific the death. Therefore, when you see the stromogenic cancer, you should report it, especially for the Gleason, the grade group 1 and 2 prostate cancer, because the stromogenic prostate cancer may impact the patient management. It's reasonable to assume that the patients with reactive stroma or stromogenic prostate cancer is not a good candidate for active surveillance, although we need more data to substantiate this. To summarize, so the unfavorable histology, when compared with the Gleason score and the pathological stage, is a more sensitive and a much more simplified predictor of metastases and survival after radical prostatectomy. Although this need to be validated in biopsy specimens. And as a matter of fact, some of the unfavorable histology, such as cribriform and IDCP, has already included in the pathology report. So the take-home message for you is when you look at the radical prostatectomy and the prostate biopsies, you really need to look for and report these unfavorable histological features. So that we can provide a better and simplified ways for the risk stratifications in the treatment guidance. With that, I want to thank you very much for spending your the Saturday night with me to listen to my talk. Thank you.
Thank you, Prof. Ming Zhao, for the very insightful presentation. So we do have a few questions already lined up for you. All right. So maybe you can take them. So we have two questions from Dr. Kaushik. Number one is, why are anosmosing cords mentioned separately from the pattern 5? And his second question is, can you give some tips on diagnosis of small incipient 5 in a C of 4? We'll start with that first.
Okay, so I'm sorry that the slide was partially obscured by this panel, the pictures, right? So what I try to say on that picture is, so if you see these anosmosing cords, right, some of them are solid, so that would be graded as pattern 5. Others have this cribriform morphology that will be graded as a pattern 4. So in terms of, if you see a C of the pattern 4, then you see a few the pattern 4 glands, right? Whether you should grade it as pattern 4 or 5, right? I mentioned to you that the single cells, the course of cells, will be graded as a pattern 5 if you see enough of them. What is considered enough? That means if you see just a single cells, you should see about at least 5 single cells in a cluster that is away from other poorly formed glands, pattern 4 poorly formed glands, so that you can be sure that those single cells or course of cells will not be the result of tangential sectioning or outpouching. If you see these single cells or course of cells are mixed with other poorly formed pattern 4 poorly formed glands, you need to see more. How much more? At least 10 of them, to be sure that they are not the result of outpouching or tangential sectioning. So the rule of thumb is if you see, you need to see many single cells or cores of cells to if they are next to those proteoformed glands to grade them as a pattern 5.
Dr. Kaushik already put another question on. Can we see that slide once more? Since in the slide showing anastomosing glands image, did you say that you would consider adjoining tubuliform image as a pattern 5?
Sure, yeah. Let me share. Hold on. Hold on. Sorry, I'm having some technical trouble here. Okay, yes. All right.
Bukan, aku mah mau
All right. So you see my screen, right? I'm sorry.
That's okay.
This, right?
Yes,
yes,
Okay.
yes, that is correct. Yeah,
Okay.
this one.
So, on this panel, right, on the top panels, right, these panels, so you see these equipiform morphology, right, it will be graded as a pattern 4, right? In these bottom pictures, so you see these solid nests or trabecula, they will be graded as a pattern the pattern 5. Some of these, right? So at least this one, okay, on the left, you'll be graded as a pattern 5, right? Because if you measure the narrowest dimension of these solid nests, right, it certainly has I think more than the 5 nuclei in these nests. And I'm not sure about this one. I probably will keep it as a pattern 4 here for this picture. Okay, but
since
definitely for these top 2 pictures, they are pattern 4.
Since we are still in the same topic, so Dr. Gerasi has posed a question: is the anastomosing cord pattern the same or similar to the small solid cylinder pattern?
Can you repeat that question again?
Is the anastomosing cord pattern the same or similar to the small solid cylinder pattern?
Small, no, they're different.
Oh.
Yeah, different. These are really you need to see these large anastomosing cords, right? If you see these small the cylinder patterns, right, that will be they considered pattern 4, at least in our study. So in about 10 years ago, we also did studies on the grading of these pattern 4 different subpatterns, right? These are small cylinder patterns, right? Which are these small columns that have 2 or 3 cells thick. That will be graded as a pattern 4. And plus, they are not anastomosing. Remember, this anastomosing cords, right? You should see these trabecula or the nests. They are connected with each other.
All right. So we go to the next question from Dr. Monique. Do you report percentage of cribriform patterns separately from the other Gleason pattern 4?
So far, no. So when the cribriform glands are present, I only report they are present or absent, right? They are present, right? I only also mention these are large cribriform glands. So again, when cribriform glands are present, I say they are present and they are large. I don't report small cribriform glands. I don't report the quantity uh, of the cribriform. I think it's a great idea. I think show the slide. Maybe I should have shown that slide. That one of the issue is we really don't know the quantitative threshold of these cribriform glands. Meaning, in the prostate biopsies, right? How many cores that should be involved by the that should have cribriform glands, or in these courts, how many cribriform glands should we see before we can actually associate the cribriform morphology with this adverse clinical outcomes? So we actually don't know that. It's right now, it's a binary association. The presence of cribriform glands are associated with the adverse clinical outcomes. The absence of it is not associated with adverse clinical outcomes. But we really don't know whether more cribriform glands you see, the worse clinical outcomes. That's something we need to study. Good question.
Since we are on the topic of this the reporting of this unfavorable histology. So we have, I actually question, I'm just going to combine it with my question. This is from Dr. Adila as well. Since we have all these unfavorable histologies, and as you mentioned in your summary that, even like least one of them has been reported as essential as well, right? The intraductal. So what about the others? How do we report them in our standard prostate biopsy reporting?
Yeah, so I think it should be the same as cribriform and intraductal carcinoma, right? Again, right now, the cribriform and intraductal carcinoma, right, by the recommendations of ISUP and the GUPS, should be included in the Gleason score, right? But on top of that, we also need to mention the presence of cribriform and intraductal carcinoma. And for these unfavorable histology, then I would say most of them are now part of the Gleason grading system, right? We have these solid, and all the Gleason pattern 5 is a part of the Gleason grading, right? And then these anesmosing cores, cribriform glands, and intraductal carcinoma, they're now part of the Gleason grading system, right? The only thing that's not part of the Gleason grading is stromogenic prostate cancer, right? So
Yeah, I
I would
was.
suggest, yeah, we do the same for the stromogenic prostate cancer, right? We'll grade it. We'll grade it. If the stromogenic prostate cancer is the Gleason, the pattern 3 or 4, we will grade as such. But we will also mention in a comment, just like we will mention the presence of intraductal carcinoma and cribriform, we'll mention the presence of stromogenic prostate cancer. We'll mention the presence of these anastomosing of the cores, and we'll mention the presence of intraluminal papillary proliferation. And then we add a comment that these are considered unfavorable histology that predicts the adverse clinical outcomes.
Okay, we'll go to another question on still within the topic of unfavorable histologies. So, Prof, in your practice, what are the most common pitfall that you encounter in diagnosing these unfavorable pathologies on a biopsy?
Yeah. So on one of the slides, I showed that in the radical prostatectomy specimen, right, the vast majority of the unfavorable histology, Gleason pattern 5, and also the intraductal carcinoma, and also, I can show you. Right. So the first three are the most common the unfavorable histology you see in radical prostatectomy, right? Gleason pattern 5, large cribriform glands, and intraductal carcinoma, and anastomosing cords, right? The last two, complex intraluminal papillary structures and a grade 3 stromogenic prostate cancer, is quite rare, less than 5% of the cases, right? In the prostate biopsies, right, in terms of how often we see these features, right, I would say certainly much less common than in the radical prostatectomy the specimens. But we often see the Gleason pattern 5 and large cribriform glands and intraductal carcinomas. And I would say really, really, we see this stromogenic prostate cancer and these intraluminal papillary proliferations. So I would say the most common patterns will be Gleason pattern 5 and cribriform glands and intraductal carcinoma.
All right. And our last question that's posed within the chat box is from Dr. Nick. What changes can we expect in the new Blue Book, the 6th edition?
Okay, yeah. So, yeah, in terms of the upcoming 6 editions, I think well, we'll focus on the topics and we discussed this morning for me, right? That will be the modifications of the reporting of the intraductal carcinoma, right? So now I think the WHO will have a very clear recommendation that the IDCP should be graded and included in the Gleason score when it is the concurrent with the invasive cancer. That's number one. Number two, I think that there will also the recommendations to the diagnose and report these unfavorable histology, and we should include them in a comment and also mention their clinical significance. Those are the two things I expect that will be included in the upcoming WHO Blue Book in terms of the IDCP and unfavorable histology.
We have one last question from Dr. Kashif. Any soft clues for this histology of the stromogenic cancer, stromogenic cancers, and pictures as well?
Okay, yeah, I think there's some soft clues, right? Let's talk about the clues. And I really don't know the soft clues, right? And I think it can be quite the obvious at the low power, right? If you start to see, I will focus on the glands, the shape of the glands. I mentioned that in the stromogenic prostate cancer, right? It's almost you almost always see these glands appear like the squeezed. I mentioned that it's almost like you pick up a gland and squeeze between your fingers. So these glands look sort of elongated and the bent or curved or angulated, right? When you see those glands, then you have to think about, I need to look at the stroma. carefully. Then you go down to look at the stroma. You will see the stroma no longer is very pink. Instead, it's a loose, a little bit pale staining. That's when you need to think about stromogenic prostate cancer.
Right. That is our last question. Any more questions from the participants before we close the session? One last one, maybe. Anybody?
So I told Nick that I'm going to send the copy of my talk to him so that he can distribute my talk to the participants.
Thank you so
Oh.
much.
Right. Okay, then if there's no more questions, so we like to thank Prof. Zhao in the usual manners. I think we are seeing lots of these thumbs up, clappings, and hearts all over the screens already. Right. Okay. So Nick, shall we wrap this session now? Is it okay?
Yeah, sure.
All right. So thank you, Prof. Zhao, for the talk just now, and to the all participants, thank you again for taking your time, your support in supporting us in this webinar. So as we come to the end of today's event, it's been a pleasure sharing the moments with all of you. Before we part, I like to take this opportunity to wish everyone, I hope it's not too early, but an early Chinese New Year. So may the year ahead bring you good health, happiness, prosperity, and success in all that you do. That goes to you also, Prof. Zhao. Thank you everyone, and have a safe and pleasant night ahead. Okay, so I end this with Jinian Kuai
Right. Thank you so much. Hopefully I will see you guys in the future meetings.
Yeah,
Yeah, thank you.
same here.
Bye.
Bye.
Hi, thank
Bye.
you, Professor
Bye.
Minzo, Zara, and Nick. Thank you so much. Have a good day.
Okay, thank you.
Can we take a picture?
Thank
Okay.
you.
Or
Oh yes,
keep
I think
taking
we
Yeah,
pictures.
take
maybe we
picture.
have
Oh, yeah.
one picture.
Sure, yeah.
Wow. Who's taking pictures? The Hangoro, can you assist us with
Yeah.
that?
Yeah, I will take the picture.
All right, thank you very much.